Welcome everybody to our virtual grand round session today that is going to be themed on sleep surgery. We have a very exciting session coming up over the next 1 hour. Um, I probably will give it probably another maybe 2 or 3 minutes, and then we can formally start. I see people streaming in, so we'll give them a couple of more minutes just to join. I think we can start. I see 50 people logged on already, and it's 5:03 p.m. So once again, a very warm welcome to everyone joining us today. From wherever you are in the world, it could be good morning, good afternoon, or good evening. Today's session is themed around sleep surgery, and we have very exciting guests with us for the next hour. My name is Taseer. I'm a pediatric ENT in Sidra medicine in Qatar, so I'll be your host for this session. I'll shortly be introducing our moderator, who will then introduce our speaker. But I just had my usual opening remark, which is just to really welcome all of you very warmly to this session. Um, and really just to again talk about the vision of our program, which is to propagate free learning and collaboration within our region. Um, a lot of us have trained and visited and gone to different parts of the world and are practicing in the region. And really, our vision is to ensure that we have enough cross collaboration, education, and sharing within our community that we really don't need to look for materials elsewhere. So we hope that this session is going to be very valuable to you. We also have a YouTube channel that's growing. We have, I think, almost 300 subscribers on that YouTube channel. So I'll paste the link to that channel right there. We're also live streaming on that channel if anyone prefers to use that. And please subscribe to that channel, share it to people that may have missed the session or may be interested in the session in the future. Um, and if you're interested to join our email subscriber list, please put your email on our hosts and panelists, or sorry, your on the chat function, and we'll put your email on our subscribed list for you to get updates and sessions as they come up. I'm just going to put my Edward, if you don't mind just pasting the link I just posted, just for everyone to see for our YouTube channel. All right, great. So I have the pleasure of now introducing our moderator for today's session, Dr. Ahmed Al-Sayed, who's an assistant professor of otolaryngology, head and neck surgery at King Saud University in Riyadh, Saudi Arabia. He specializes in sleep surgery. He earned his medical degree at King Saud University in 2014 and completed his residency at Dalhousie University in Canada from 2016 to 2021, and his fellowship at Stanford University from 2021 to 2023. Dr. Al Sayed also holds a graduate degree from the University of California, Berkeley, and the University of California, San Francisco in biomedical engineering and healthcare entrepreneurship. Um, it's a pleasure to have you, Dr. Ahmed Al Sayed. I have to say, from a personal standpoint, we crossed a bit during our paths while at Stanford, and every time I would speak to Ahmed, he would be always such a an optimist, a positive, motivated person, and his energy really is really something that I really admire. So it's lovely to have you and your energy. I'll hand over to you.
Thank you very much, Taseer. And you've put together an excellent educational program with the virtual grand rounds. We're really honored to be here and privileged to be able to share our knowledge with all of the people that have tuned in. Um, I'd like to introduce Dr. Yousif Al-Ammar. Dr. Yousif is my colleague, a very close friend. He is one of the very few people who is actually dual trained in rhinology and sleep surgery. So he's befitting for our talk today, which is a very common issue that we see in our clinics. Dr. Yousif did his general otolaryngology training at McGill University in Canada. During that time, he also managed to get a master's degree in science in otolaryngology and the basics of research. Following his general otolaryngology training, he did a rhinology fellowship at McMaster University in Canada as well. And then after that, joined the Stanford Sleep Surgery family and did a sleep surgery fellowship. Um, Nowadays, Dr. Alammar is also an academician, so he practices out of King Saud University in Riyadh, Saudi Arabia, and is an assistant professor. And he is, an all-around great guy, and hopefully, a lot of the people who tuned in will get some valuable information from today's talk. So I'll hand it over to Dr. Yousif. But before we do that, I just wanted to, gauge the experience of the audience by polling them with a few questions, just to see what is, the level of knowledge and the current practices that are prevalent in the region, as well as, having this as much, as interactive as possible, just to keep it less monotonous and also, just to keep it more fun. So perhaps Edward, we can start off with the poll, and then following that, Dr. Yousif is going to talk to us about his experience in answering these questions, and this will be the recurring theme as we go through the talk, and then hopefully we'll be able to manage to finish the talk in about 40 to 45 minutes and open up the floor for questions towards the end, just to get everybody to see the upcoming match, Egypt versus Argentina, which is, I think, an important also viewing. All right, so Edward, if you don't mind, could you start off with the poll? All right, so we've got 7 questions here. I'll give you a couple of minutes just to go over those questions and answer them. Again, this is aimed to understand the different practices in the region as well as the current level of knowledge. And then Dr. Yousif is going to share his knowledge and expertise as it comes to these questions.
Ahmed, you're muted.
All right. So we can we can now move on to the talk and have Dr. Yousif share his experience to see, whether or not the answers kind of align with the audience. So I see here the first question. It seems like the majority of people think that it's not necessarily a major contributor, but it also is not a minor contributor. So the majority kind of falls in the middle. They think it's a moderate contributor. Um, so we'll see if that is true or not in a minute. And then when it comes to the physiology, I think most people agree that all of the different uh, mechanisms stated in the question are contributing to the pathophysiology of obstructive sleep apnea. The third question during DICE, the changes in pharyngeal collapse. It seems like the majority of people do see some changes with nasal maneuvers during DICE. And then for the fourth question, the majority of people think that nasal surgery can cure OSA and selected patient populations. So I'd be interested to actually see what the verdict is on that question in a minute. What is the primary benefit of nasal surgery in patients with OSA? The majority of people think that it's primarily an adjunct to improve CPAP adherence. And when it comes to correcting nasal obstruction before advanced surgeries like hypoglossal nerve stimulation or maxillomandibular advancement, it seems that the majority of people do think that that is a worthwhile endeavor prior to these procedures. Okay, so now let's listen to the expert, to Dr. Yousif, sharing his experience when it comes to answering these questions and comparing the answers or comparing his practice to the prevalent practice. You can take it away, Dr. Yousif. Thank you so much for your time.
Thank you, Ahmed, for the great introduction. And thank you, Taseer, for arranging such an amazing program. It's a pleasure to have this great opportunity and looking forward to, for more collaboration and more growth of such things in the region. And I'm just having some challenges with sharing my screen. Um, just give me a second. Are you guys seeing my talk?
Yeah, we can see it now.
Okay, perfect. All right. So I'll start with a quick introduction, and we'll touch base on some of the some of the answers of the questions that we just raised, and it will be always a good chat with you, Ahmed. So feel free to pitch in and add your thoughts here. So nasal breathing is been an obsession for years, and it's gaining more obsession lately. So there's books been published about it, and there's a lot of promotions, materials that been commercialized to help with nasal breathing. Like nasal dilators, strips, mouth taping. It's always been promoted to help with nasal breathing. And that leads me to the a question that I always encounter, and that will help us during this talk, is when do I do nasal surgery for obstructive sleep apnea patients? Do I start with it always? Is it always the easy step to do at the beginning? And is it appropriate for every patient? And again, what does it help with? And as well, is it a solution or it's just an adjunct? So obstructive sleep apnea with nasal airway obstruction is reported in up to 70% of sleep disorder breathing patients or OSA patients. Common structural issues is septal deviation and turbinate hypertrophy, reaching about 85%. Soft tissue obstruction from nasal mucosal edema, such as rhinitis or nasal polyposis with CRS, contributes to nasal obstruction in this population. About 65% of the patients using positive airway pressure reports nasal congestion or nasal dehydration. And then some studies showed an association between higher resistance and inferior turbinate hypertrophy with CPAP intolerance or non-adherence. There is a small study of oral appliance users that showed it increased nasal airways, nasal airway resistance predicted oral appliance non-response. So that leads us to, okay, what's the link here? What's the link between obstructive sleep apnea or sleep disorder breathing and nasal airway obstruction? So there are a couple of theories. Here, the first one is the Stirling resistor model. So the theory is when a space in the middle between two fixed or rigid areas, it's tend to collapse more when there's a higher resistance. And that's what's happening in the pharyngeal airway. It's sandwiched with the nasal airway and with a trachea. So if there is any resistance in those areas, the pharynx tend to collapse more. So that's one of the theories here. It also predisposes those patients to oral breathing, which tends to collapse the tongue and causes airway obstruction. One of the theories as well is the nasal ventilatory reflex. So if the nasal airway is patent, it leads to an increased spontaneous ventilation and improve upper airway muscle tone. And with the opposite, with an obstruction, that will be also the opposite. One of the theories is also nitrous oxide mediated mechanisms. So it's a potent vasodilator, may play a role in the upper airway patency. So the theory is it does regulate pharyngeal muscle tone, regulation of spontaneous ventilation, modulation of the sleep-awake status, and the role of nasal breathing and nitrous oxide regulation in OSA still remains a bit unknown. So let's talk a bit. Okay, we do the surgery. Does it really help? So a couple of meta-analysis looks into that and pulled, different papers that looked into nasal surgery and its effect on obstructive sleep apnea. And the change after nasal surgery still remains limited in terms of significance. If anything, it's going to decrease the AHI by 4 points. This is in one of the meta-analysis. The other two, they even didn't find any significant results here. However, it does help with the sleep quality. So there is a significant change in the upward sleepiness scale. And then when we look a bit deeper into the types of surgery, specifically septoplasty, there is an RCT that looked into septoplasty versus sham surgery, and AHI remained unchanged, but upward sleepiness score decreased in the group that underwent septoplasty. And then when we look into functional endoscopic sinus surgery, we know that it improves the quality of sleep and duration. It helps with the REM sleep, but there's no improvement in the PSG respiratory parameters. Then the other thing is turbinate reduction. There's a small placebo-controlled study that assessed the effect of radiofrequency turbinate reduction and noted improvement in CPAP use, but not in the upward sleepiness score. But they didn't look specifically into the PSG parameters. Adenoidectomy. Without tonsillectomy, it showed OSA as improvements, specifically in kids. And then when we look into nasal valve surgery, there is no specific study that just looked at it in isolation. There's a small study with 20 patients, and it did show a little bit of improvement. However, it didn't reach to surgical success by the Sher criteria. And it does also improve the REM, improved the total sleep and REM sleep time. The clear thing about nasal surgery that it does help with CPAP tolerance. So in this meta-analysis, they looked into patients who had sleep surgery and then using CPAP, and it reduced the average CPAP pressure from about 11.5 to 9.5. And that converted about 89% of non-PAP users to PAP-tolerant users. And that leads us to the question about DISE and the relationship with DISE and nasal surgery. And a couple of studies looked into that about, okay, a patient who had nasal surgery, does it really change the airway pattern? One of the initial papers in 2012 didn't show any significant change. However, it showed some partial improvement in the palate collapse. And then when we had another paper in 2020, they said, no, there's actually significant change. And before nasal surgery, 74% of the patient demonstrated multi-level. And after nasal surgery, that showed 50% of them only. So, which is, a considerable amount. And then when we look into single level, the oropharynx was the most common location of obstruction, and it became more frequent after nasal surgery. And one of the interesting things they said that its significant improvement was shown in the hypopharyngeal collapse. One of the latest surgeries that also included a functional septoturbinoplasty. And there is a shift in the dynamics of the palate, oropharynx, and tongue base and the epiglottis. And then, interestingly, all the cases of a complete AP collapse of the epiglottis changed to partial collapse. So those are all, interesting findings. The question is, and that's the challenge with drug-induced sleep endoscopy, is what does it mean and how does it improve the patient outcomes, which is still an area of ongoing research. One of the questions that we had was, okay, what's the relationship with with nasal surgery and hypoglossal nerve stimulation? And the theory behind that, patients who get hypoglossal nerve stimulation are a unique population. One of the challenges with them is insomnia. And we know that allergic rhinitis contributes to that as well. And the question is, does prior nasal surgery help with response to the stimulation or to the adherence to the device? And this recently published study didn't find any significant relationship between those. So this is probably the slide for the first part of our talk. And I'm wondering if you would like us to move to the poll again.
Yes. Edward, if you don't mind just putting up the questions that the audience has answered, just so we can go over them as a quick summary. All right. So maybe Dr. Yousif, I'll have you to answer these questions with me. So for the first question, so what are your thoughts? Do you think that the audience is correct in their assumption as a moderate contributor, or what would you say?
So it is, that's the challenging part about sleep, It depends. It's always depends. But I don't think is isolated nasal obstruction plays a major role in the OSA as a general statement.
Yeah, I agree with that. Okay, for the second question, you showed some beautiful slides in terms of all the different pathophysiological mechanisms that links nasal obstruction with obstructive sleep apnea. So I have the tendency to agree that all of the above are probably at play. Okay. So the third question, that was a very interesting study that you showed and very interesting results, to be honest. So what are your thoughts? People do think that frequently is it's something that these nasal maneuvers do change the
I
dice.
it plays a role. Now the question is how often. We still, all of these studies, they had a small sample size. So I think we need a larger study that looks into more details. And then that's always the debate that we have, Ahmed, is what does that mean? It
Absolutely.
changed the pattern of the airway. Okay, how that's going to help us improve the patient outcome at the end. And I think that's where, things are hidden.
Absolutely, absolutely. And the two things that we always, keep saying about DICE is that DICE is not necessarily physiological sleep. So what we see and what we observe during a DICE might not be actually something that translates with 100% certainty to actual sleep, including, nasal maneuvers and the collapse patterns, because that can also change um, the actual pharmacological basis of the drugs that we use for DICE. Okay, number four. I think this is very common in our region. Can isolated nasal surgery cure obstructive sleep apnea in appropriately selected patients? I guess this is a two-pronged question. Number one, what is an appropriately selected patient? So who is the ideal candidate for nasal surgery in OSA? And then number two, the causal relationship that you just explained in the beginning of this talk. So what would you say from your experience?
So if we take it as a general statement, the answer will be no. But when we look into, isolated, selected patients, that's when things are might come into use. The way that I approach it with my patients is if he's a mild OSA patient that is bothered by the snoring, and he has a significant nasal structural abnormalities such as severe septal deviation, significant turbinate hypertrophy, then those patients are where I tend to offer it in isolation, and I tell them like, okay, we are gaining the nasal airway, the better nasal breathing anyways. So why not do it and hope that it will might change your OSA as well. And I would say in those patients, it might, it generally helps them. But and as a general statement, I'm very cautious, and I never promise those patients.
I agree 100%. I would say the only study that I looked at, and it's the only study that I'm aware of actually that specifically went on to answer this question. Um, Basically, like the whole result of the study was it depends on the rest of the airway. So nasal surgery can be curative for OSA if they had a good retropalatal space, as well as like no skeletal maldevelopment, and otherwise, healthy with no significant hypoxic burden. But also, what you mentioned was also true. So in these patients, what are we treating? So are we treating the daytime, issues with nasal obstruction versus what they experience at night? And I don't necessarily think that mild obstructive sleep apnea in the absence of a high hypoxic burden needs to be treated anyways.
That's
But
the,
I,
yeah.
I completely agree. All right, so number five, the primary benefit of nasal surgery with the OSA. So the majority of people, identified improving CPAP as an adjunct is a worthwhile goal. Do you tend to agree with that?
I totally agree. And also in terms of the sleep quality, I think it does help. And again, as we discussed, reducing AHI, it's usually, a very small chance of reducing it.
Yeah,
And
I
so,
really absolutely. I really like the study that you presented. They're comparing septoplasty with sham surgery. So the problem with the nose is that a lot of it is subjective, and you can't really eliminate the effect of placebo from these studies unless you actually do a proper randomized controlled trial with a sham surgery and then looking at the subjective outcomes. So I really like that study. That actually changed a few things in my mind. All right. So 6 and 7. When it comes to doing nasal surgery prior to advanced therapeutic modalities like upper airway stimulation or MMA, the majority of people do think that it is worthwhile. So what are your thoughts? I mean,
so we
especially
had,
in the light of the study.
yeah, so we had that hypoglossal nerve stimulation study, and I tend to agree with it. It doesn't, again, it doesn't influence the OSA part, but it might help with, nasal breathing, daytime symptoms, and sleep quality. And then when it comes to MMA, now it's a bit of a different ball game here, because you need to consider, your surgical steps and what considerations you want to do. You want to make sure you have a good impaction with the nasal septum. So it might be a wise thing to do it during the MMA, or if there are some patients, they want to do also a rhinoplasty, which we tend to tell them, like, okay, no, wait, don't do it during the MMA, postpone it to after the healing, and then judge, because there's a lot of things, a lot of features on the face change at the same time.
Definitely. I agree with that. So especially for the MMA question, I think that you can save the patient a trip to the OR by doing the septoplasty and the turbinate work during the operation, during the MMA. But obviously, this is also something that is very fluid. So if they required a rhinoplasty due to aesthetic changes post MMA, then you can probably do a septoplasty then. And that should not necessarily, like, should be an open discussion with the patients. Okay, thank you very much.
For MMA, we have, I know the majority of people who does it are OMF surgeons, and they tend to have a good training in terms of performing septoplasties and nasal surgeries. And also, it's not, if it's for the better of the patient to involve an ENT and come help with that part, then we tend to be a collaborative specialty, and I think we'll be happy to help with that.
Absolutely, absolutely. Okay, well, thank you so much for answering, the first batch of questions. You did answer a question about, the effect of nasal surgery on snoring. So this would be the second segment. And I know this is a hot topic because a lot of people back home, at least in Saudi, are interested in that question, whether or not, doing nasal surgery does anything to snoring specifically. So Edward, we can close off this poll and initiate the second batch of questions that links nasal surgery with snoring specifically. And as we wait for the questions, it may be just like a quick couple words because it is also a very common question that we get. What is the relationship of snoring with OSA? Are they 2 points in a spectrum of the same condition, or they're related or could be unrelated? So maybe a couple words, Dr. Yousif, about the relationship with snoring with the OSA for our audience.
So, snoring, it could be, an issue by itself, or it could be the tip of the iceberg. And that's how I usually explain it to my patients. I tend to go with, a couple of, pointers when I evaluate the patient. And if it's a young patient who's thin, who doesn't have any skeletal deficiencies, no clear airway abnormalities, then we could, settle on, it's probably just snoring, and we just need to tackle that. But if I can have a patient that's, who's more on the older side, obese, have some, skeletal deficiencies or airway abnormalities, or developed some, complications of the OSA, such as high blood pressure, then we tend to like, no, you're probably on that spectrum of things, and we need to address also OSA and order a sleep study. The good and the bad, we're in Saudi, we're a two-tier system. So it's easy to get a sleep study when you're in the private setting, but it's very hard to get it when you're in the public healthcare system. So there, it makes you very selective for who do you offer it to, and in the private, it gives you that liberty that to order it for the people that you think they will benefit from it.
Yeah. Maybe as we wait for the audience to answer those three questions, another question that popped up in my head, and I did not include in those polling questions. So you get a patient with nasal obstruction. Do you offer them nasal surgery first, and then a sleep test later if they are complaining of sleep issues? Or if they were complaining of sleep issues from the get-go, the first step is to get a sleep test before doing any kind of surgery. So, what are your
if
thoughts?
I have a high probability that he will have OSA, I tend to order the sleep study first. But it's not always the case, because majority of those patients, and you probably see it in your practice also, Ahmed, that they get already been operated. So
Yeah.
the nose part has already been done. And sometimes one of the challenges is they thought it's the cure. And in retrospect, I wish that at least you could have ordered a sleep study and saw what's going on before doing the surgery.
Definitely. Yeah, I think the positive predictive value of whether or not they have OSA is the key determinant, I believe. Okay, so Edward, we could probably close off this poll, and then look at the answers very quickly, and then we'll have Dr. Yousif talk to us about the relationship of the nose with snoring specifically. Okay, so the first question. How much does isolated nasal obstruction contribute to primary snoring? So the majority of people think, again, moderate, not a major, not a minor contributor, but more kind of they're in the middle. So we'll
Do
see.
you want to start answering this as we go?
No, we'll keep it at the end after your slides.
We don't have
Yeah.
much slides on the snoring. That's why it could have.
Oh, okay. Okay, we can answer it if you want. So what do
Yeah.
you think?
So I'll just give a general couple of statements, and then we'll go over them. So in general, snoring, literature-wise, there is nothing that supports nasal surgery and improvement of snoring. If anything, the best paper there that said it's around 30% of improvement. So it brings us back a little bit to the same point that when we said, okay, when do you offer nasal surgery to OSA patients? I think the same criteria applies here. So if it's in isolation, there is nothing else happening, then that's when we probably consider nasal surgery to start with, especially considering it will improve the daytime symptoms.
Got it.
And
Yeah.
for this question, I would say only in selected patients.
Fair enough. Fair enough. So patient, which brings us to the second question. Which patients improve the most from nasal surgery, I guess? Like if they had snoring, what are your thoughts? So the majority of people think that if they had isolated nasal obstruction and otherwise a normal, airway downstream, those are the people who are really happy generally from performing nasal surgery for their snoring issues. So what do you think about those?
I agree. I think this is the population that I'm going to select for nasal surgery.
Same. Yeah, same. I tend to agree with that as well. So for the final question, can nasal surgery make snoring worse? I get actually a lot of questions from rhinologists saying that, oh, why does that happen? Like we operated on our patients for the sake of alleviation of snoring, and they came back to us with worse snoring. And what do you think is going on, and why does that happen? And it has led a lot of rhinologists to actually counsel patients, telling them that we could do the nasal surgery, but I don't know, and I do not guarantee the outcome. So your snoring can get worse, or it can get better, or it can disappear completely or not change. So it seems that the majority of our audience thinks that this is not an issue. The majority of patients do improve, or their snoring at least improves after nasal surgery. So what are your thoughts about this question?
So I think it's a question that comes from reality, and it does happen. And we get those patients that they complain that, oh, doctor, my nasal breathing is better, but the snoring didn't improve. It's actually got worse. And I don't think there is a good answer to this yet, scientifically supported. But my thoughts that, yeah, we released an area of obstruction, but and that's when it comes when we say there's proper selection. Those patients probably had some retropalatal collapse or other upper airway collapse, and it just got worse with the increased airflow.
Yeah, I agree. And I don't know, like this is just an observation, and I don't necessarily have anything to back this up from a science perspective. But I noticed that the more aggressive nasal surgery you do, especially to the turbinates, the more you reduce the turbinates, the more patients, well, they have the tendency to be happier from a nasal obstruction standpoint, but for some reason, they are more likely to have worsening of their snoring. I don't know if it's because of turbulent airflow or, as you mentioned, having more air pass through different structures in the upper airway, creating more sound or the noises of snoring when everything is relaxed during sleep. But it is an observation. Um,
Looking into and studying better.
Definitely. So what do you think? So after this, do you have slides about these questions that we can go over quickly, or
Those, I think we covered them. We could, move to the next part and chat about it.
Okay. So Edward, thank you so much for putting this poll up. Could we put up the poll, the next section, the relationship of chronic rhinosinusitis with obstructive sleep apnea? All right. So in this section, we have a bunch of questions that having Dr. Yousif being a trained rhinologist, dealing with a lot of chronic rhinosinusitis patients, I think it's an important topic to discuss, the relationship of chronic rhinosinusitis with OSA. Do they just coexist because both of them have high prevalence, or one of them causes the other, or one of them influences or modifies the other? So these set of questions, I guess, are aimed to understand the relationship between the two conditions. So we'll see what the audience has to say about them, and then I think you do have a few slides about those.
Yeah.
Okay. So maybe after we stop the poll, we can go over them and then revisit them afterwards to discuss the answers. We'll give it one more minute. All right, Edward, you can stop the poll now, and we can revisit it after Dr. Yousif goes over his slides.
Okay. So CRS or chronic rhinosinusitis, it's been, found that 15% of CRS patients to have comorbid OSA. PSG confirmed OSA was identified in approximately 65% of CRS patients undergoing surgery. And the preliminary research has suggested that immune mediators associated with CRS may contribute to sleep disorder breathing. And then one of the revolutions in terms of in terms of management of chronic rhinosinusitis is biologics, and we will come to that. I think we have a couple of questions, so I don't want to burn that segment. And then we also, in terms of allergic rhinitis, this specific population, it was found that around twofold or two times of those patients of ARS patients tend to have moderate to severe OSA, independent of any other factors. Allergic rhinitis tend to cause snoring, sleep fragmentation, decreased sleep quality. And then when we look into the PSG data, it does show worse sleep efficiency, oxygen dehydration, sleep fragmentation. Although these results are mixed between, the different studies that we have on this topic. Obviously, when we talk about the medical treatment for these diseases, the first line is topical corticosteroids. It does have a minimal impact on OH and on AHI, but it definitely does improve the daytime sleepiness and sleep quality, especially in the allergic rhinitis phenotype. However, the CPAP adherence impact is still undetermined in terms of the topical corticosteroids. And when we look into oral antihistamines and leukotriene inhibitors, there is no significant impact on AHI. It does improve the total sleep time and REM percentage of sleep, and it doesn't have any sufficient data on the CPAP adherence. And we keep in mind that that's probably due to the sedative effect of some of the oral antihistamines. One of the treatment options for nasal obstruction is nasal dilators. It doesn't have effect on the AHI in general, but however, in a small subset of these patients who have severe nasal obstruction with a valve collapse, they tend to benefit from the nasal dilators. It does show also some small reduction in apnea index, and it lower the required pressure on the CPAP device. So, Dr. Ahmed, we could go back and review our poll.
Excellent. Edward, can you put up the previous poll? Let's look at the answers. All right. So the first question, primary contributor to poor sleep. The majority of people thought it's all of the above, the nasal obstruction, the inflammation, and the pain. What are your thoughts?
I think I agree. It seems to be the whole spectrum of the disease that it's annoying and bothersome to the patients.
Okay. Now, for number two, a lot of people actually thought that CRS causes OSA, but the majority do think that they're associated with an unknown causality. So what are your thoughts?
I think I agree with the majority, and they're associated, but there's still, some figuring out need to be done.
Yeah, I'm actually quite surprised at the a lot of people thinking that CRS can cause OSA. I'm not quite sure why, but definitely chronic diseases can coexist together, especially when you have two conditions with a high prevalence.
I think one of the things that probably people might think about it is CRS with nasal polyps and having that nasal obstruction, complaint. But again, it comes down to the same discussion that we had earlier, that those patients tend to, if you improve that, they have a better sleep quality, but not necessarily improve the AHI and the OSA part.
Okay. The third question, just like tying into that, the majority of people think that the most bothersome symptom that causes impaired sleep is nasal obstruction.
I personally agree. I think that's what majority of the people complain of, especially when they're trying to use the CPAP. Tends to bother them.
Yeah. So what about those with like smaller polyps? Let's say if they had disease that's not necessarily obstructive, what do you think would be the most bothersome symptom? Would you still think it's the nasal breathing?
It might be more the postnasal drip.
Yeah.
Uh, it tends to be, bothersome. It wakes people up, and you know, that same question could be applied on the reflux patients, where they're bothered by the postnasal drip or the burning sensation that wakes them up.
Yeah. Yeah, I agree. And then for the final question, what is the most consistent outcome after endoscopic sinus surgery?
It tends to be sleep quality. I agree.
Yeah, I agree with that as well. But it's interesting to see the distribution. A lot of people do think that AHI um, improves, particularly after endoscopic sinus surgery. And there is a question in the chat that I'll probably bring up in a second. Um, but I don't necessarily think that that is true. CPAP requirements. What do you think about pressures? I do think they have the tendency to improve after endoscopic sinus surgery. But what are your
Yeah.
thoughts?
Again, it's majority of us when we do endoscopic sinus surgery, we're not just clearing the sinuses. So if there's polyps, we're removing the polyps. We are reducing the turbinates at the same time, and oftenly we're also doing a septoplasty. So it's hard to just put it in isolation that endoscopic sinus surgery in general is going to improve the CPAP requirements.
Oh, interesting. Um, this is a sort of a question that relates to that I get a lot of the time from the residents, and I'm kind of interested to see what you do in your practice. A lot of the residents, when we have a patient who has endoscopic sinus surgery and they are CPAP users, ask me when should they go back to using CPAP. So, what has been your experience, and what do you usually tell those residents or tell your patients in terms of resuming CPAP after endoscopic sinus surgery?
Um, so, if I'm not mistaken, there was one of the study that I came across, and it should be okay to start it, as soon as possible. The only, special population or are those with complications. So if there was a lamina propria violation, or uh, God forbid, if there is any, skull-base injury, then those are, you need to be cautious with them. And also for skull-base patients, when you do, tumors and you have a CSF leak and all of that, those you tend to wait on them and don't start the CPAP. It's the same, discussion about when do you start the patient on CPAP after sleep surgery. When you do a palate, how soon do you start them? I don't know about you, but I tend to tell them as soon as possible. You could go ahead and
Yeah.
start.
Same. Like honestly, like for both sinus surgery and for sleep surgeries, I have them start CPAP on post-op day 0, to be honest. Like the night of the like after the surgery. Unless there's obviously a complication with the sinus procedure, not wanting to have that air or that pressure go into untowards places. So before we move on to the next segment, because I feel this is related. So we got a question from the audience that states regarding the rules of surgery for treatment of OSA, why there's conflicting data that comes from different researchers and papers, especially nasal surgery and its effect on AHI, also DICE results. Also, there are some papers showing that it's very important before every single surgery, but there are papers that show that DICE didn't change the decision of surgery. I guess those are like multiple questions all on once. So I guess the first part of the question is asking why is there conflicting data out there in the literature when it comes to the role of nasal surgery and its effect on AHI. And then the second, yeah.
Yeah, I think
Go.
This is, the meta-analysis. That's what brings all that data together and gives us, proper, conclusions. And that's how the evidence, grow. And I think the answer that we had three good meta-analysis on this topic, and they're all having, very, supportive on, nasal surgery improving OSA.
Yeah, there's a lot of heterogeneity, definitely, in terms of all the papers out there. And we don't really understand the pathophysiology as well as we do. So now the whole world of sleep surgery is moving towards phenotyping patients and understanding their anatomical needs. But it also goes beyond that in understanding their physiological needs and endotyping them as well. The second question is that it relates to dice. So
That's a whole different.
that is a whole. So maybe we'll keep that towards the end. So Edward, could we pull up the questions that links OSA to allergic rhinitis?
So I think for the sake of time, Dr. Ahmed, I already finished my slides. We just have the summary slide. So if you want to go through the whole question and the questions and review them, that will probably help us.
Yeah, this one shouldn't take long because you've already answered some of these questions. So we'll just give it, just 30 seconds to have people go over them. And then maybe very quickly, we go over the answers. All right. I think, Edward, we can end the poll and show the results. All right. So, symptom with greatest impact on sleep, nasal obstruction again, which I think is true. I agree. Just like with chronic sinusitis. All right. The second question. Does allergic rhinitis increase OSA risk? What do you think?
Again, there is an association between the two. They tend to have, twofold the risk compared to, regular population. So I would say yes, modestly. I agree.
Yeah. And then finally, would you treat their allergic rhinitis before getting a sleep test, or you would get them to have the sleep test regardless?
So that's the thing is, when do they come to you as an ENT or as a sleep surgeon? So if they came to me before the sleep study, I tend to optimize the nose, medically before doing the sleep study.
Yeah, same. But I don't necessarily think it impacts my decision as much to get a sleep study. I would still have them get a sleep study regardless whether or not and for how long they've been treated for their nasal symptoms.
I agree.
Okay. So Edward, thank you so much for this set of questions. Let's see the second set of questions, which kind of brings it all together. The use of biologics in OSA or for OSA in particular, whether for allergic rhinitis or chronic sinusitis. All right, so just a couple of questions. We'll give it another 20, 30 seconds, and then we can go over the answers. I know that for a fact that a lot of pulmonologists, let's say, and sleep medicine, the sleep medicine folks, do have the tendency to treat allergic rhinitis or chronic rhinosinusitis if their patients had asthma and OSA, and they've seen some improvement in the disease burden when they start them on biologics. But I'm actually quite intrigued to see what your experience has been, because you probably use biologics a lot more than I do. So I don't know what kind of outcomes have you seen with that with those. But let's also see what the audience think. All right. I guess Edward, you can stop the poll and let's look at the answers. So seems like the majority of people think that if the patient had polyps, that it's worthwhile to consider that as a treatment for OSA. So what are your thoughts?
So I'm not sure again as a treatment for OSA. It comes again to the same philosophy of managing nasal obstruction. So yes, it will improve the nasal obstruction, it will improve the CRS symptoms. We might gain some benefits with OSA, but it's not guaranteed. And even, at the point that you raised with some pulmonologists with treating their patients with OSA on biologics, there's not that strong evidence that supports that. Yes, biologics has revisionals, like the whole rhinology world. So even the rhinologists feel that they're threatened by biologics and they're afraid to be out of work, which I don't think it's true. But that's one of how good they are. But I think we need to be cautious in terms of putting that relationship with OSA.
Yeah, fair enough. I agree. There are people that actually start that I've met like in the professional settings that actually start patients on biologics prior to anything, prior to surgery, prior to like the only thing they would do is medical management of the nose, but then they would start them on biologics, even if they did not have polyps for allergic rhinitis or something only like mild inflammatory burden.
So
The next question.
lines for that, and it definitely, there is a ladder that you need to follow when it comes to putting them on biologics.
I agree. The second question is more interesting because the majority of patients do the majority of like our audience did think that the future of sleep apnea care relies on combined pathway, which also includes precision medicine. So endotyping and phenotyping the right patient, but also a collaborative approach. But not a small percentage of people thought that biologics are also a future practice changer when it comes to sleep apnea care. So
I
that's a very interesting finding.
Yeah, I hope we get some evidence that supports that, because that will be, again, the way that it changed the rhinology world. I hope that it also changed the OSA. And we have some examples on medication that did change the sleep apnea world, like Zepbound and the GLP-1s and how they helped with obese patients.
Okay, that's excellent. All right, so the final set of questions, and then we can conclude. We can open up the floor for discussion from the audience to type in their questions into the chat box. So Edward, could you pull up the last set of questions? All right. So these are the concluding statements, I guess. Based on what has been said and what has been discussed so far, I guess the second question is an important one for our trainees, because a lot of people are considering different subspecializations within ENT. They're considering different fellowships. So that's a particularly important question I feel that I get from a lot of the trainees. And having you done both, I think you're the best person to answer that question. All right. So Edward, we can close off the poll and look at the answers. All right. So first question. I guess based on your talk, a lot of people do think it is the first step, but obviously it's not the only thing to be done for obstructive sleep apnea. So what are your thoughts?
So again, it comes down to the proper selection. So if we selected the proper patients, yes, it could be the first step. But majority of the time, it's just part of the package and could be more of a getaway to sleep. That's what I think. And I'm not sure what you think, Ahmed, also.
I know I agree with that. I think it's a very important piece of the puzzle, but the puzzle has so many different components, for sure. But patient selection is key, understanding why we're doing the procedure and counseling the patient in terms of like what are the expected outcomes are very important. The second question, I guess for all of the trainees, it's a close one. A lot of people think it's 62-38. I mean, the majority do think that you should have rhinology training, which is honestly very logical because a lot of the prominent sleep surgeons come from a rhinology background. So what are your thoughts about that?
I believe it comes in handy, that the background in rhinology does help. But I wouldn't say it should or it's a must. It's good to have a strong, background of nasal surgery in general. It will serve you well. So having a good training in residency, good exposure in rhinology, that will help you. So don't skip on those ORs.
Nice. All right. And final question. What best reflects your practice, just as a concluding statement, when it comes to the relationship of the nose and OSA? The majority of people think that you should optimize nasal disease. Um, but it's an even spread. Like the rest of the options pretty close. So what are your thoughts?
Um, I tend to believe that all of them apply into certain extent, but definitely the majority of the way that we look into it is we optimize the nasal disease and we improve symptoms so the patient can tolerate CPAP and other modalities. That in terms of a nasal part. But when we find that there's other things that they're contributing, that's when we go and target them.
Excellent. All right. So we will conclude with some questions from the audience. I believe we have the second part of the first question. Maybe if we can answer that in like 2 or 3 minutes. Like the relationship of DICE and surgical selection. So what are your thoughts about that, please?
So, the lately we've been getting more robust evidence on the utility of dice, and one of the things that he probably pointed out that there is a clinical trial that they looked into doing dice or no dice and assessing the difference in surgical outcome, and they found those population who didn't have dice, they had a better outcome. And another study, a prospective study, that found that there's not much of a difference between the two. That lead us to, okay, put us into, a bit of, a break mood and start like looking into, okay, what are the true relationships between DICE and outcomes? So there are specific findings that we tend to look into rather than just, going with that traditional understanding of DICE being a targeted approach tool. The way that I look at it is a tool that helps you not to fail more than helps you targeting the obstruction. So I tend to do it when I have a plan in mind, but I have a question if the patient has like multi-level obstruction or have a pharyngeal wall obstruction, or they have a concentric collapse, or if I'm planning to do them if they failed after surgery, previous surgery, or if I'm planning to do a major surgery for them, such as hypoglossal nerve implant or MMA. So that's, summarizes the utility of DICE. So I think it's not more of a, the answer for the question. It's not a conflicting evidence. It's more of maturation of the evidence that we have. And I think it still has some way to grow and to become more of a standardized procedure.
Yeah. And now the second question that we have also has two parts. So someone is asking, what do you think is the optimal duration of DICE? Because if you wait longer, you might observe more obstructive patterns. So what are your thoughts about the optimal duration of DICE?
That's a tricky question. And I'm not sure if I have the good answer to it. The way that I tend to do it is make sure that the patient reach the proper depth before starting the DICE. Once they reach that level, I tend to stop in each area and give it at least 2 cycles of obstruction. And with every maneuver that I do, I give it time to have 2 cycles of obstruction before proceeding to the next step. So all in all, like when you have a good anesthesia team that's supporting you, it should take you around, 15 up to 30 minutes of doing the DICE. That, just doing the diagnostic part, in isolation of, the expanded DICE utilization, such as using the CPAP or the oral appliance and the other stuff.
I agree. So in that sense as well, it depends on the agent being used. So obviously, if you're going to use something like dexmedetomidine or something like that with a slower induction phase, it'll probably be longer than 5 minutes, because in order for you to actually achieve an adequate depth as assessed by a BIS monitor or something like that, you would need 10 to 15 minutes. So just to sum up, the questions about DICE, I think the role of DICE is more prognostic. It has shifted away from being a tool to assess the sites of obstruction to assessing the chances of success from surgery. So it's prognostic, not diagnostic, I guess. The second question is asking specifically about the diagnostic modality, whether or not you have any experience with the watch pat. Particularly when an full in-lab PSG is not available. So what are your thoughts about, peripheral arterial tonometry, and how does it relate to or correlates with, the findings from a level 1 study?
So, when you say that it's not available, that kind of is like that kind of answers your having a test at least that helps. But when we come having both options, it comes also handy, because we know with level 1, one of the challenging things is the patients say that they're not in your usual pattern of sleep. They prefer to be in their own bed. So that's why there is like a specific criteria on who do you offer PSG or level 1 sleep study compared to a home sleep test or less supervised tests. So I think that is the way that I usually go by. And also I have, our colleagues in sleep medicine, they tend to support us with that as well.
Definitely. I would say any kind of objective data is better than nothing. So a watch pad is definitely better than nothing when these are the only options. Although, their original validation study showed a 96% correlation between findings from a watch pad and a level 1. All right, we have a couple of more questions about DICE, actually. So
we need to have another session about DICE.
Definitely. So they're asking whether or not DICE is a decision that you would go for at the same day of the planned procedure, or you would do it at a separate day. Like, do you do a DICE and then you do the procedure, or you separate between them? Yes.
I think it comes down to the surgeon preference and the setting that you're in. I tend to like to do it on separate days. I do the procedure, I do the DICE, I wake them up, I show them what I've seen and explain things into detail. And then we tend to move ahead with surgery. Some people like to do DICE and proceed. I think it's all reasonable options.
Yeah. And then the second question that's also related to DICE is that is it important for medical legal from a medical legal standpoint? So in other words, is DICE the standard of care? So do you have to DICE every patient before you proceed with sleep apnea surgery?
I think it depends where you practice. If I'm practicing in Saudi, then the answer is no, like in Saudi or the Gulf region, because it's actually, it's unrecognized by a lot of, healthcare bodies. So if you look into insurance companies, they don't have it even in their policies. But if I go to the US or other countries, then yes, for specific procedures, it's considered to be essential. So if I'm doing an upper airway stimulation, then it's the standard of care to do DICE before.
I agree. I mean, it hasn't really made its way in terms of guidelines because DICE can also be misleading, right? So it's not a must. So if it's not a must, it's not something that would make you liable if you don't do it. I hope that answered the question. And then maybe the final segment about the question asks, the differences in doing DICE in a governmental setup versus a private hospital. What are the differences, and would that influence your decision, doing or not doing a DICE?
I like one of the challenges in the private sector, it's getting the approval. And to be honest, I only recommend it either ways if I believe that I need it. And if I believe I need it, then I push hard until I get it. So I've done some, things until I got, the patient approved. And sometimes they go and they complain and they do official complaints until they get it.
Definitely. Well, I think that's it in terms of questions from the audience. Oh, maybe not. Got one more. Okay, do you usually do DICE with CPAP and or oral appliance, and what are the outcomes? And that's the first question. The second question is, what do you see the future of upper airway stimulation in Saudi Arabia?
So do I do it often? I would say no, but I do it for some patients when I have a question of why he's not tolerating those devices. So one of the utilities of DICE is to help you identify the obstruction with those treatment modalities, and then you target it surgically. So it could be like somehow an adjunct surgical intervention. The future of upper airway stimulation, I think, it's part of the treatment modalities that we should have. And I think it will be in our toolbox soon. But we need to be very cautious in terms of who do we offer it to and, the outcomes of it and promising the patients, the outcomes.
That's excellent. I think our time is up. I really would love to thank Taseer for making this all happen, and thank Dr. Yousif for his valuable insights and experience. I personally learned a lot from this talk, even though I have been practicing for a couple of years. So really, thank you both for this amazing educational opportunity.
Thank you, Ahmed, for moderating the session. It's been also always great working with you on different talks and different academic events. And Taseer, it's been a great pleasure. And you heard the people; they need another session about DICE. So let's make it happen.
Well, thank you very much, guys. I learned so much in this session. It really was an honor and a pleasure listening to both of you speak so expertly, but also so humbly and almost in a very friendly fireplace or fire chat manner to our audience today. So thank you very much once again for lending us your time so generously. I think we're past the hour, so I think we'll close off the session right now. Edward did post that we do have a YouTube channel, so if you missed part of the session or if colleagues weren't able to attend the session altogether, please share the YouTube channel with them. We will be posting the recording of the session very shortly. Subscribe to the channel, and our next session is going to be in September. Our next session is actually on laryngology on 1st of September, so we'd love to see you then once again. Once again, thank you very much, Dr. Ahmed, Dr. Yousif. God bless you both, and we'll see you next time.
Thank you. Bye.
Thank you. See you next time.